part of our virtual cafe translation conversation series. Today we are very excited to be joined by Professor Victor Montori. And this seminar today is hosted by the Co-Design Living Labs Network. And my name's Jen. I'm a research fellow and lead of the Co-Design Living Labs Network as part of the Alive Centre. So welcome. We're going to go through and do a bit of an introduction to an update of what the centre's been doing and things, and then we're going to head into the seminar and some Q&A and things as we go forward.
So thanks, Jen. And I know we're going to just spend a little bit time settling in, and as is customary, I'd just like to acknowledge our traditional custodians of the lands that we're all meeting on. Here I'm meeting on Wurundjeri land, and I pay my respects to elders past, present and emerging, and encourage you to share where you might be joining from as well, anywhere in the globe and indeed locally in Australia. Just acknowledge that sovereignty was never ceded. And I think it's important in the context of this presentation and the conversation that I know Victor will be bringing to the table today as well, to just recognise all of the lived experience that is in the room and the virtual room today, and that we always attend to speaking honourably and respectfully about emotional distress and ongoing experiences of trauma and mental ill health. And it just popped down the bottom there that we have those beautiful values of the National Centre around honouring lived expertise, practice wisdom, being outcomes driven, authentic, inclusive and being brave. And these were all co-created at the beginning of the centre's setup, and we always commit to demonstrating those in all of our actions and work. So I know, Jen, you're going to give a little bit of an overview after our update here of the actual Co-Design Living Labs program, just to socialise that with everyone. I know Nargis, one of our co-leads, is working with you today. But just before that, I think it's helpful to see that we have a number of research activities underway, and just highlighting on our slide here that, you know, the Co-Design Living Labs network and our membership base across Victoria and now nationally is the backbone and is at the heart of what we've set up in the National Centre. And it's been delightful to expand that beyond as we've set up Alive, but just noticing its integral role here within our activities. So I have a number of research projects underway, and I won't dwell on those, Jen. We do have a centre update that's come out, and that means that you can go and take a look at those within your own time, and feel free to ask any questions back to the group anytime you like. Also within that centre update is a bit of a year in review. And this takes us through across from 2022, the start of our last symposium, which was in March 2022. And you can see how far we've travelled along the journey. And again, I'm not going to dwell on this and take up valuable time in hearing from Victor and your story and all of the network, but just highlighting that we continue to grow. We have a very strong lived experience research collective, which is very much a research program fostering lived experience-led research and ensuring we have an embedded model of lived experience within all of the centre activities, right through from governance down to our day-to-day work. And that is also a program and a tailored arm of our Next Generation Research Network, which is focused on building and growing capacity of our next generation of future mental health research leaders. You can see our Co-Design Living Labs membership is 2,000 plus people. And we also have 55 people who've joined the Alive Collective, which is our general membership supporter opportunity where people can't find a place somewhere, which is pretty hard in the centre, but where people might say, really want to support that special initiative in mental health that the National Health and Medical Research Council funded and funded us for 5 years. And I want to show my support by joining the Alive Collective. So we're setting up some strong foundations and strong pathways forward. And it's wonderful to hear from you, Victor, in light of the topic of revolutions and evolutions and all those things. But Jen, before that, I'll just let you give a bit more of an overview.
Yeah, thank you. So today we have, as we said, we're being hosted by the Co-Design Living Labs Network, and we thought we'd share our team here. And I just wanted to bring in and introduce Nargis as one of our lived experience co-leads of the Co-Design Living Labs Network. And she's going to be taking you through a bit of a just very brief introduction, and we'll introduce Victor as well as we go forward. Nargis, are you there? Yeah, great.
I'm here. Hello, everybody.
Great. So you can see here that this is our team, and we've got 8 co-leads, carer co-leads, and lived experience co-leads, and we've also had 3 co-designer trainees join us as well this year. So it gives you a bit of an overview. It's nice to see some faces. Nargis, did you want to go through this, or would you like me to?
Yeah, I'm happy to. Thanks, Jen. Hi, everybody. Nice to meet you. As Jen has introduced, I'm Nargis, and I just wanted to acknowledge the Bunurong people of the Kulin Nation and pay my respects to elders past and present as well. So here at the Co-Design Living Labs Network, we operate on an end-to-end research design to translate model driven by lived experience, and the program was established in 2017 by the University of Melbourne Primary Care Mental Health Research Group. The first wave members were from the Diamond study, which was a study on the experiences of depression over 10 years, and the core study over 5 years examining co-design implementation and services in Victoria. More than 2,000 people with lived experience or mental ill health and ongoing distress and trauma, including a smaller number of carers, family and kinship, are members. And the model has evolved over time and now includes a co-lead group for each membership group. So I'd like to introduce Professor Victor Montori. So Professor Victor Montori, we're really excited to have you here. Thank you for being able to fit us into your very busy schedule. He is a professor of medicine at the Mayo Clinic in America and is an endocrinologist, health services researcher and care activist. He is the author of more than 700 peer-reviewed publications and is among the most cited researchers in clinical medicine and in social science. He is a recognised expert in evidence-based medicine, shared decision-making, and minimally disruptive medicine. He works in Rochester, Minnesota at Mayo Clinic's Care Unit to advance person-centered care for patients with diabetes and other chronic conditions. He is the author of the book We Revolt and is leading a movement, a patient revolution for careful and kind care for all. Please welcome Professor Victor Montori.
Thank you very much, Nerys, and thanks everyone for the invitation. It's a real pleasure to be here with you, and unfortunately, this approach of having one presenter suggests that there's somebody that gets to monopolize silence for a bit, and I'm going to hopefully not do it for too long, as I am really interested in hearing your reactions to what I have to discuss, but also how this affects you and how you might see it related to your own experience. I'm going to share my screen here, and I have a few slides. When people say I have a few slides, you got to get ready for like 3 hours of presentation or something like that. So let's see. Can you see the title slide? Okay. Yes. All right. So in this title slide, there are 2 pieces of information that you might want to hold on to. One is my Twitter handle. So I know Twitter is declining rapidly as a place of exchange, although it really hasn't been that safe for particularly for vulnerable people in a long time. But anyway, I am there. If any of you are there, feel free to share any and all of this content as you see fit. And connect with me later if you have any other issues that we don't get a chance to discuss. My email address is also there, and I have the bad behavior of checking it all the time and respond to it very frequently. So feel free to just write me with comments, and Victoria can testify that I try to respond very quickly, and although not often very effectively. Just checking, audio is coming through all right? Okay. It's always important to look at disclosures. I'm a salary clinician. I'm actually at the Mayo Clinic right now. I just finished with patients this afternoon. Well, I didn't finish with patients. That sounds horrible. Like I just ended there. Anyway, yeah, just finished seeing patients this afternoon at Mayo. That's where all my income comes in as a salary clinician. I work in the care unit, as Nargis mentioned. I do not derive any personal income from the research activity, but also we decided very early on that as a research unit focused on knowledge and decision-making, that we would not take any for-profit funding for funding our research. I'm the chair of the board of the Patient Revolution, which is a nonprofit organization. I don't derive any income from that activity. This book has already been mentioned. The sales of this book, the royalties, go directly to the Patient Revolution. So as you can see, I am a terrible business person. This is the opportunity I have to recognize a few things that I think have been globally experienced, particularly during the pandemic. This activity depicted in this picture, care, has been front and center, has come out of the back rooms of the house, of the domestic and private space, where it's unseen and unrecognized. And for the briefest period, we've celebrated, we've honored it, we've recognized its importance, but also in that process, we have seen many of our colleagues who have been called to that privileged space of the bedside to lose their lives, to lose their health, or in many cases to lose their vocation and abandon healthcare. Many of those worldwide who lost their lives or their health because they were at the bedside of patients with COVID-19 were from the global South, mostly women of color, mostly immigrant women, just like the well-known fact of the brain drain, the world has a substantial care drain from the global South to the global North, which reflects a massive pathology in the way care is distributed. The tasks of care are distributed worldwide, but also at the level of each of our countries, with many of the care duties landing on women, many of them landing on poor women of color. When you see that, you know that care is therefore not an activity that is rewarded, that is recognized, that is honored to the extent that we've seen for the briefest period during COVID. It is care that we're going to be discussing today. And unfortunately, care hides, not only because, again, it's activity that we delegate to women, that we keep in a domestic space, that we keep private most of the time, that we keep unrecognized and unrewarded, but the care is also an activity that when we even discuss it academically or in our environment, we find it insufficient. And so we add a number of adjectives to it. And so we talk about sick care or health care or patient-centered care or evidence-based care or high-value care. And when we do that, our attention immediately goes to those adjectives. In evidence-based care, we start discussing the evidence and and the research quality and the science and the validity and applicability of that science in relation to care. When we talk about high value care, our eyes and our attention go to what value is and how might we measure it and optimize it. And care, being the most important word in any of those phrases, remains undefined and not with much attention. So let's focus a little bit on it. Care is a practice, so it's a series of activities. The group here speaks of design. Design and care have a common set of attributes. In fact, one of my dear colleagues, Dr. Ian Hargraves from New Zealand, speaks of this myth of care, this goddess that fashions a human out of earth, and then takes some wind and gives it life, and then it creates a big debate among the gods as to who owns this human, because the earth claims the body. I think I don't get my gods all lined up correctly, but I think it's Jupiter that claimed the wind, the soul of this human, and so there was a big debate as to who, and then of course Care was the one that fashioned the human out of the mud, and so Care wanted to claim the human for herself, and so they called on Saturn to decide on what's going to happen with this human, and Saturn decides that the day that human dies, the flesh will go back to the earth, the soul will go back to the skies, to Jupiter, and while the human is alive, it'll be under the care of this designer that designed Care. So there's a connection between care and design that's very strong. But it's also a disposition to notice and respond, to notice, and pay attention and be present to see what is this problematic human situation that the person needing care has, not only appreciating the problematic aspects of it, but also the strengths and assets that person brings individually and as part of their community. And then to mount a response that has the magical effect of creating the possibility that these needs will be met. It creates the possibility, invents the opportunity for hope. It's also a disposition towards caregiving and care receiving. Caregiving, which is done with the person, not to the person, with competence so that we can do more good than harm, and with compassion and empathy. But also care receiving, which is the only way really we know that our care has actually been pertinent, adequate, and desirable to the person receiving that care. So care requires that feedback built into it to make sure it's always appropriate. Now, I take care of patients with diabetes and patients with chronic conditions, and these are the patients that most commonly come to healthcare worldwide, and particularly in developed countries. So in primary care or in the care of chronic conditions, there are additional factors. One factor to consider is that if we approach the person needing care with any other intention but the intention to care, trust suffers. And trust is an essential element in creating a care that actually heals. And then the other thing, that if you do this repeatedly, you will develop an enduring relationship. This enduring relationship has important value. On the one hand, by knowing each other for a long time, we can detect very easily and earlier any difference in the way people are functioning in the world, and we can respond in an opportune way. But also, the most common outcome of care is disappointment. And when we get disappointment, we have to fall back on the relationship where we can regroup and recast our line and try to go forward again. Without this enduring relationship, after the disappointment, the person in need of care goes adrift and might find themselves being cared for by people that do not have their best intentions or are there to profit from the situation of despair. So ongoing care has an additional value. Currently, most healthcare systems do not offer the conditions that are propitious to care, do not create conditions that foster care. And one can see this where we come to health systems where patients are seen too fast, or are seen as a test result, or are seen as a statistic, the uncontrolled person with diabetes, or the clinicians fall under the spell of the medical record, thinking that because they reviewed the medical record, they know the person. But in fact, through all this, the real person remains nothing but a blur. Here's Maria Luisa in a little bit higher definition, and we see her at her house in front of a lot of medications. And so you would expect to see her healthy, but she's not. She looks sad and tired and lonely and overwhelmed. How did we respond to Maria Luisa if she was nothing but a blur? Well, we have guidelines, we have clinical targets and innovations, but those are all for people like her that respond to her biology and the biology that she has in common with people with the same diagnosis. But that's not the job. The job is not to take care of people like Maria Luisa. The job is to care for Maria Luisa. And that requires us to understand not just her biology, but also her biography. And by biography, I don't just mean where she's been, where she's at, where she wants to go, but also the same trajectory culturally of the community that where she comes in. Patients that belong to groups that have been minoritized or racialized or discriminated against, or have been suffering from violence, structural violence, that is imprinted into their experience of being alive and being in society. It's part of their biography. It affects the way disease manifests. It affects the ways treatments are accepted and the way treatments are rendered safe and effective. So without fully accounting for a patient's biology and biography, one is not really fully caring for that person. And without that, our care becomes generic. When people have multiple chronic conditions like Maria Luisa, that generic care accumulates and creates work. These are photographs taken by patients with diabetes who have experienced the work of being a patient, and we ask them to reflect that in photographs. So, of course, the work of figuring out what to eat, the work of self-monitoring. The most common picture we got was the work of waiting to be called about an appointment, waiting, to get to the appointment, waiting in the waiting room, waiting in the office, eventually getting care, be sent out for tests, waiting for the test to occur, waiting for the test results to come back, waiting to hear back what we're going to do next. Where I work, where insurance determines what is affordable, is waiting for the insurance authorization for the tests or treatments that we have to do. It's waiting and waiting and waiting. Because all this work is invisible to the healthcare system, more progressive systems, progressive in quotes, find that patients and families are the most underutilized resource in healthcare, so more work comes to them. And so we ask patients to come prepared for the consultation, to watch our educational videos, which happen to be hilarious, to organize their information prior to the visit, to bring questions, be ready to ask new ones, to record the visit. That way we can speak very quickly. They can slow that recording down back at home and explain to their loved ones what went on just by listening together to our beautiful voice. And they can, ask them to review the medical record and fix our typos, to communicate via portals and transmit data from their devices. We're not going to really look at them, but it keeps them engaged. To self-measure, to self-monitor, to self-manage, to manage their appointments, their prescriptions, their bills, their denials, delays, to overcome the disadvantages of whatever illness labels they carry, or resource limitations or identities that they may have, to keep family and important others informed, to take care of significant others, and of course, to advocate for themselves and for others. This is all extremely reasonable. It's a reasonable set of expectations and a reasonable list, a list that unfortunately accumulates onto each other and lands on the shoulders of people who are already overwhelmed. But this is very burdensome to patients and families. And this, of course, in addition to the labyrinth way in which we set up our not only our facilities, but our procedures. And when people do not do what we expect them to do, we call them non-compliant. which of course is a label, is a sticky label, that is a label that applies to the person and their personas, not to their circumstance, not to their situation. And it's a dead end, because clinicians, when faced with the patient with this label, know that there's very little they can do to improve their situation, as that label implies the patient is not taking personal responsibility and initiative in advancing their own health. So when people come in for care and we label them and treat them without seeking to understand, with curiosity and empathy and compassion, healthcare becomes cruel. So this is industrialized healthcare, a healthcare that instead of caring for people, sees them as nothing but a blare response with generic and burdensome treatments that sometimes are cruel. Industrial healthcare is healthcare without care, and without care, healthcare is unsustainable. I'm not talking about financial unsustainability, I'm talking about human unsustainability. Family members and patients with chronic conditions report, 40% of them report having to deal with unsustainable burdens of treatment that is in excess of what they can tolerate, and that might lead to a discontinuation of important aspects of that care. When patients and clinicians get together, they meet in agendas that are full of must-dos, that leads clinicians to interrupt patients within 11 seconds of them reporting why they're there. Thanks to COVID, now we know that you need to wash your hands for 2 happy birthdays for 20 seconds. So 11 seconds, about 1 happy birthday song that patients have to tell us why they're there. And if you have an electronic medical record, clinicians spend about 40% of the time facing that medical record, filling in the fields and the demands for data that's there to document the care instead of turning to the patient to care for that. And without ability to connect to patients in a personal way, around 60% of clinicians are experiencing or reporting feelings of dispersonalization and loss of empathy, feelings of burnout. 40% of clinicians, if you just want to remember one number, 40% of clinicians are planning to or have left clinical care. And so this is a healthcare that is not sustainable, because we lose our professional caregivers, because the caregiving moments are interrupted by all sorts of industrial tasks, and the people seeking care are already overwhelmed with the care tasks that have been transferred to them. What is the way out? This is the Cathedral by Rodin, and this one of my favorite statues and one of my favorite sculptures and sculptors. And when Rodin, for Rodin to make this cathedral, which by the way are 2 hands from 2 different people coming together, almost touching, the hands and the fingers making the walls and the spires of this cathedral, the space between the hands being the space for the cathedral becomes useful. The sculpture had to free that space from the rock that's there, from the marble that's there. Create that space requires subtraction, taking whatever was getting in the way of these hands coming together to be useful. And that is the work that we have to do. We need to work together to create the conditions for care to happen. And so we'll have the conditions right, conditions that are set up by our organizational policies, by our leadership, by our culture, by procedures and policies, by what incentives and disincentives are in place, by the way we work together and organize ourselves. We will know we have those conditions right when we are able to foster unhurried conversations. I think the unhurried conversation is the most important innovation in care. It is in the unhurried conversation. I'm not talking about long and boring. No, the unhurried conversation is the space in which clinicians and patients can notice a situation that requires action in high definition in its biology and its biography, and then respond by co-creating, working together to co-create a solution to that problem that makes sense, that makes intellectual sense. It's evidence-based, it's safe, and reflects the situation as we understand it. It makes emotional sense as it attends to the suffering associated with this situation and the potential joy that may come up from finding the solution and implementing it in life. And it makes practical sense. It doesn't overwhelm the capacity of people, and it respects what they're trying to accomplish in their life. One of the methods to achieve this is shared decision-making. One of the approaches to promote that, to create the conditions for that, is to create tools that are available to people to have those conversations. This is an example of one such tool. Is for people with diabetes trying to decide which diabetes medication to consider next. And so we ask patients what aspect of this, and we show them the titles of these cards, which aspects of these tools do they want to discuss first. Some of these patients with type 2 diabetes may be concerned about their weight, and they would like to understand the effect of medicines on their weight. And they see here 2 medicines that are capable of helping them lose weight. So they're interested in those. So we ask the patient, what aspect of those medicines are you interested in next? They might be interested in how you take it, to find out that this one may require injections. And so, if I'm going to lose weight, I'll inject my eyeballs. That might be interesting. But this one is a daily pill, and that might be better for them. And so we asked them what aspect of that one would they like to discuss next. And where I work, out-of-pocket cost is important. And maybe at this point they discover they can't afford really this medicine. They might just with their eyes go back to the one where they were injecting, and also find that perhaps it's not as affordable to what they're used to. These are 100 times more expensive than the metformin that perhaps they're currently taking, only to find that perhaps they might need to tolerate perhaps some weight gain to take a pill every day to achieve their goals with only 10 cents a day. But the most important thing is not the selection necessarily the patient will make through this system, but it's the conversation that this system allows the patients and the clinicians to have, where the clinician then gets insight into what are the things that matter in the life of the patient and how the treatments can be made to fit. In addition to having the right tools, it's sometimes helpful to have the right space. And so here is a particular space design in which the clinical area, the medical procedural stuff is set aside to create a room without any distractions that has limited opportunities for interruptions, in which the table is set up in a semicircular fashion, already the furniture indicating that the space is for shoulder-to-shoulder collaboration with the information set in the middle of that table. We've been doing work in shared decision making for the last, almost 20 years now, and what we found through this experience is that patient and clinician satisfaction go up when patients and clinicians work together to form plans of care. Again, very important in the face of overwhelmed patients and exiting clinicians, that we have the ability with the extra support to particularly support those folks that have perhaps less educational opportunities as they got sick, and so we can bring their ability to participate to the same level of those who may be able to access these same resources on their own. We have variable effect on clinical outcomes, adherence to therapy, and cost of care. Oftentimes, this shorthand is used. If we just involve patients, we can save a lot of money and we can make the treatment and stick to the treatments. But unfortunately, in our clinical trials, we have not been able to demonstrate any of these effects with any consistency. And then there's a concern that if you engage patients in conversations in clinical practice, that it will take longer. But what we found repeatedly, study after study, is that this is not the case. That if you have enough time to care, which is a big if, in many places, clinical encounters are 5, 7, 10 minutes long, and that is not enough time for care, let alone for shared decision-making, particularly for patients with chronic conditions, with complex situations, unless you have adequate time. If you have adequate time, engaging the patients in shared decision-making or not takes about the same time. What to do with this problem of non-compliance? Well, we need to relabel this and focus on the situation of the patient, which is a situation of an imbalance of workload and capacity. And very quickly, we see from this description that we can improve the situation by either decreasing the workload or boosting the capacity. What contributes to patients' capacity? A sense of purpose, resilience, health literacy, attentional bandwidth, physical, mental health, financial health, and social and environmental connection with the community. All these things contribute to capacity, and so they are subject to be boosted. To reduce the workload, we might use shared decision-making to prioritize, use the platinum rule, which is not like the golden rule, do unto others the way that you would like done unto yourself, but the platinum rule, do unto others the way they would like done to themselves. So you need curiosity and understanding of what patients value and what matters to the person. We need to ban these medical errands when we tell patients to go and do things that the system should be taken care of, and send the patient through the administrative labyrinths of our system, oftentimes designed to reduce care. We need to apply tools of quality improvement, not just to the production of healthcare services, but to the consumption of those services. So for instance, people that use lean, there's an opportunity to actually do lean consumption. How might we reduce the waste on patients and families of all the effort and time and attention that we ask them to invest in consuming our services? And as we move towards the digital transformation of healthcare, we have to be extremely careful not to reproduce digitally the same transfer of work and burden that we have managed to apply in the way we organize our healthcare. In fact, ideally, the digital transformation should also contribute to reduce the work of being a patient. There are forms of coaching, capacity coaching, that might help and boost capacity along with self-management training, particularly early on in the trajectory of chronic disease. Palliative care, absolutely essential in patients with chronic conditions, a huge population, much, much bigger than the population at the end of life, in which palliative care seem to often find its practice niche. Patients with chronic conditions who can't sleep, have pain, have shortness of breath, and are fatigued might benefit from the attention to the symptoms as a way of boosting their capacity, not just to be a great patient, but boost their capacity so they can live their lives fully while taking care of their own care. And then all sorts of psychotherapy, physical therapy, occupational therapy to boost the function of what works, as well as social work to connect with community resources and community strength, where we can actually boost people's ability to care for themselves. This approach of managing workload and capacity has been dubbed minimally disruptive medicine, aware of advancing patients' priorities while reducing the healthcare footprint on their lives. In fact, one could easily imagine a goal of care as that of making care fit in the life of patients. And a couple of years back, an international group put together this manifesto, which I find terribly inspiring. And in it, there's this phrase, which I think indicates a potential north, a potential goal for the work that we do. Patients and clinicians must collaborate in designing care plans that maximally respond to each patient's unique situation and priorities, while minimally disrupting their lives and their loves. To make that happen, we must work together to create the conditions for care to occur. And this, we are in our organization, the Patient Revolution, we see this as a long journey that requires a strong community, that we share language, knowledge, and insights. I've been sharing those today fairly quickly, and that we partner organizations and communities and individuals for radical change to realign healthcare, that take it away from this industrialized form to a form of careful and kind care for all. What can all of us as leaders do? Well, we can notice these pathologies of care, hurry, blur, cruelty, and burden, and identify the alternatives and make them happen by making care the core purpose of healthcare organizations, preventing distractions from other means, and then working together to respond with radical change, affecting the rhythm of that care, the opportunity to notice and respond, and with minimizing the work that will take to care well for folks. There might be some early signs of success in our journey. This is a picture of a TV show called The Resident. Here is the fictional CEO of the hospital that is depicted in this show, season 6. And during the whole season, on her desk was a copy of Why We Revolt, which of course was pretty fun for me, particularly when one of my classmates from medical school in Peru told me that your book is on TV, and that was pretty exciting. Now, it would be better if the CEO was real, and healthcare leaders were using some of the language that we've used today to advance this mission, to take care from the means by which organizations achieve their purpose to the purpose of those organizations. A subtle shift, but it makes a big, big difference. To invert the accountability. Right now, increasingly, patients and clinicians are held accountable to meeting targets of care by a large bureaucracy. It should be the other way around. Patients and clinicians should hold that bureaucracy accountable for providing the resources, particularly time, uninterrupted time and attention to be able to care. So we need to invert that accountability. By all means, we need to eradicate cruelty from our healthcare system. It's helpful to think of care as very similar to love. The opposite of love is not hate. The opposite of love is indifference. The opposite of care is also indifference. And when somebody in need of care arrives in the healthcare space to talk to and work with healthcare professionals, and what they receive instead is indifference, that is fundamentally cruel. And that should be a never event, like the amputation of the wrong leg. And we need to see more unhurried conversations appearing in our healthcare environments as evidence, as early signs that we're making progress in moving away from industrial healthcare to a healthcare that is based on solidarity and not greed, on integrity and not rules and regulations, on elegance, which is this notion of no haste and no waste, as opposed to simply efficiency. The focus on care for this patient, not for patients like this, that is minimally disruptive of their lives and loves, and that over time generate enduring relationships that are not transactional, but in fact, oftentimes are relationships of love. That's what we're pursuing in the patient revolution, and that is the work that we're doing to foster careful and kind care for everyone. Well, I stop here and I look forward to your questions and comments. Thank you again for your attention.
Thank you very much, Victor. That was fantastic, very inspiring. And as Vicky put in the chat as well, I think, you know, we can all kind of see a lot of similarities with the work that we're doing in the Alive Centre as well. So it's fantastic to hear about your work a bit more.